Good morning, everyone. Almost noon here. I know everyone is waiting for lunch, so sorry to be between you and the lunch. I'll try to get done as quickly as possible. Thank you, everyone. My name is Hussein Ezzeldin. I'm here from the FDA Center for Biologics, FHIR for short. A long list here of departments and divisions. You can take a look at it. Today I'll be speaking about the BEST, which stands for Biologics Effectiveness, Safety, Innovative Methods Exchange pilot that we ran on eHealth Exchange. Let's get it started. So first of all, anything I say here is mine. FDA is not responsible for anything, so just blame me. I'll give you a quick background. I'll speak, of course, about the exchange pilot. I'll try to share some of the results, and then, of course, wrap up with the conclusions and summary. I'd like to start with this slide because it gives you an idea about the broad range of products that our Center for Biologics, regulates. It varies from products that are administered to all the population, case of vaccines here, to some of the products that are given to very small number of patients. You're probably thinking about maybe 100 patients a year, very rare diseases. So we have a wide range of products from vaccines to gene therapy and cell therapy. And this also goes to the clinical settings that we are dealing with, which spreads where our data or the data we're interested in lives. So this is just to give you an idea about the size of the issue that we are dealing with. So what are the challenges? We are speaking about a current manual system that relies on manual detection, it relies on manual validation and manual reporting. What all this relates to, this relates to when a patient receives a drug and there is an adverse reaction or adverse event that needs to be reported to the FDA, there are multiple steps that take place before we know of this adverse event. And at this point in time, all this is done manually. What we envision to achieve is to shift this from either an automated system or maybe a semi-automated system. So we are hoping to get to an automated detection, meaning that instead of relying on the physicians to go and raise their hand and say, this is an adverse event, I want to tell FDA about it, or I want to tell other public agency about it, we have something in the background running, some logic in the background running that can collect these different aspects of a clinical case and actually inform the clinician, say, you know what, this might be a case that you want to report, and pulls all the relevant information and then gives this to the FDA. And of course, if you are able to flag these different elements relevant to a case, then you might be able to aggregate them into maybe a nice interface and makes validation way easier for a clinician to look at the case and say, oh yeah, this looks like a case, I want to report it, or no, I have a different explanation and that's not it. So looking also at validation, we can reduce the burden of validation. That's also another thing that we're looking at. And then of course, simplifying and streamlining reporting, this is a very important point. At this point, a physician has to go either fill a report by hand, or a nurse has to do this, or they can go to a web portal, open a PDF and start entering the data and then send it. All these are barriers. And what we're aspiring to do is that we're aspiring to use innovative methods to be able to improve the quality of these reports, improve their quantity, not because we want to see more adverse events, but we want to make sure that we're getting the right level of reporting. But most importantly, at the same time, reduce the burden on clinicians and hopefully the patients. You've been hearing individual access patients all around, so maybe that's something else that we can speak about in the future. All right, so what you see here, this is a diagram that shows you our best platform. And on the left, this is how we interact with eHealth Exchange Hub. And our system has multiple components. It has a data quality service. So we get the data, we run data quality tests on it to make sure it's complete, it's conformant, and it's plausible. And then we run it through what we call a phenotyping or a detection service to highlight these important data elements in the case to be able to send it to the validation and reporting component, which I was speaking about, which is like a very nice interface for the clinician to look at the case and make a very quick determination whether it's actually, whether they see evidence for exposure, they see evidence for the outcome itself, can they assess causality between the exposure and the outcome, and whether there's any information about the severity of the outcome itself. So all this is done within our best platform, but of course we can do nothing without getting this information from, except from eHealth Exchange. So we have two use cases. We have the pull use case, which is the validation. Very quickly, starts from our knowledge of an adverse event. We have a report of an adverse event, and we want to get additional clinical information. So what we do, we go to eHealth Exchange, tell them, we know that this patient reported an adverse event. We want to get additional information. And as Jay mentioned multiple times, we only focus on what's really minimally necessary for our use case. We only pour about 16 to 19 FHIR resources to populate a VERS-like report, a vaccine adverse event report, and then send it to the FDA. So we start from there. We send the query to eHealth Exchange. They send it to the participants, which are the participants in the pilot. If you get a match, you pull these resources, you bundle them, and then you send them to the eHealth Exchange, to the best platform. We show them to a clinician. He reviews them, and that's the validation case. The more fancy one, the more futuristic one is the detection one, because it's a little bit more complicated. You need to run phenotypes on your system, on your back end, detect the cases, bundle them, and then send them to eHealth Exchange that will send them to us, to the best platform. And we have been able to do this with Cedars. You're going to hear Cedars-Sinai. You're going to hear about this, and also VHA done a push use case with us. And you're going to hear from Todd from VHA and Dr. Duncan as well. To give you an idea about our pilot, we had 12 participants, 11 non-federal and a VHA. So these are the private, the non-federal participants in our pilot. If you lay over the locations from the VHA, this is the wide coverage that we have over the country. And going to the results, I know that this is not easy, but what you're looking at here is that on the x-axis, this is percentage of completeness. And the more things to the right, the more good things are. And you can see here that for the critical elements that the critical data elements that we are pulling from the participants, most of the things are on the right, are on the 100%. There is variability between the partners on some of the fields, but in general, we have found that what we needed to make a determination about the case is there in the data. But of course, there are challenges. So to wrap up my part, we have found that overall, the data quality actually meets our requirements. Of course, there's some work to be done. But we also, as I mentioned, found variability between EHR vendors or providers, even though they are using the same vendor. We found some gaps. We worked with some of the EHR vendors to address these gaps, and we are continuing to improve our use cases, our efficiency, as well as to conduct more studies to push this work forward. And I cannot really thank enough eHealth Exchange and our early adopters, VHA and Cedars-Sinai, for their work. And I included some references for you to look at further. Thank you so much.
Good morning. My name's Todd Turner. I'm with the Department of Veterans Affairs, Veterans Health Information Exchange Program. I'm Deputy Director of our, overseeing our technical components, specifically our query-based exchange. We have our partner DoD in the room, I think. That's Crystal and Neelam. Hi. So if you guys heard somebody mention how much they love the Joint HIE, because we push so much information out there. So that's one of my areas of focus. We do a lot of state registry work with our immunization reporting, PDMP, direct messaging. I've got my partner engagement team led by Cindy Pan. Please wave over there. But I'm here today. I was asked, one of my focal areas, one of the things that gets me excited is wanting to do health information exchange by way of FHIR. You know, for years I heard talk about it, theoristic speaking about it quite a bit, and I'm a man that says, hey, I want to do this. Let's see if we can do it. So Eric Heflin, are you in the room today? Please stand up and wave. Thank you, Eric. So Eric reached out in April of 2021, and I think it was to Cindy, and said, hey, is the VHA interested in doing some kind of FHIR pilot? And we're like, well, maybe, sure. And he gave us like 4 different possibilities. And of the 4 that were out there, this adverse event reporting really resonated. And I said, I think this can be done. See, I'm in charge of this, aren't I? Green. So I want to tell you in the short time I'm with you today, kind of like where we are, or where we've been, where we are today, and where we're going with this particular effort. First and foremost, what we strive with our program in Veterans Health Information Exchange, I stole this particular slide. My content development lead, Maurice Wall, some of you may know that name. She was at an HL7 conference a few months ago, and somebody presented this slide, and I was like, yes, this is what we should all be striving for, to advance data usability. The most important thing is if the clinician cannot use the data, there's no point in us doing all of this middleware stuff. So we want to be focused in things that we can control as a smart sender. We want to make sure that our data is right 100% of the time. Are we always right? Absolutely not. We can do a lot better. I know this. I have a clinical data quality team that reviews data every day, and we need a long way to go on our side of the house within the VA, and in our partner community can do a lot better as well. But these are the things that we want to focus on: be a smart sender and be a resilient receiver. We want to make sure that the user interfaces that are available are able to consume the data that's coming across these pipes and are usable at the end of the day. So my journey here with the FHIR R4 collaboration started with Eric saying, these are some things that we'd like to do. And it's really about relationships, right? So he introduced me to Dr. Ezzeldin, who just spoke. We've developed a tremendous relationship over the last couple of years of doing this work together. I had to work with my Office of Information and Technology to see what platform out there do we currently have, what kind of technologies do we have that might be able to do this type of work. Our Vista Data Integration Federation Enterprise Platform is such a system that we have that serves multiple purposes within the VA, to include supporting the Joint HIE, our PDMP work, and our immunization reporting, among others. But we wanted to start with a proof of concept. Can this really be done? So we were able to do a point-to-point, query-based, starting with the FDA, querying over a test case over to the VA, and we were able to, it was all FHIR initiated, queried and responding with a FHIR message. So we were able to do that in September of 2021. Then I spent the next number of months trying to get my IT team assembled, funded, then get an IT team assembled to ultimately start our phase 1 push case, which kicked off in August of 2022. Let's see. The other thing I had to do as part of this process was develop another relationship. I had to become a used car salesman, and I think I did a pretty good job, which I reached out to my adverse event reporting team lead, his name is Vaughn Moore. I wish he was here today. But I had to cold call him. I didn't know who this person was. I never interacted with the pharmacy benefit team that much, at least as it related to adverse event reporting. And I said, have I got a deal for you, right? I've got funding, IT funding, and I want to modernize your system. And he's like, who in the world is this? But regardless, I was able to convince him and my team, more importantly, who are really the brains behind what we do. I'm just the dumb guy that tries to make sure money is around and people are available to do the work. But he was receptive, right? And I was able to get him engaged, and we worked on the COVID vaccination, immunization, and specifically focused on that use case and the adverse events that were tied to COVID vaccines to be able to push that information over to the FDA. We were successful in January of 2023, and I really scared Eric Heflin and I really scared Dr. Ezzeldin because they didn't think that this would happen. And we're like, we're ready, it's ready, are you guys ready to consume it? And Dr. Ezzeldin, I think he was saying, no. But we worked so well together to make that use case work. Where we're going, or where we are today, we're transitioned now over to our phase 2 query response. Dr. Ezzeldin's team has been on a bit of a pause, just end of year, fiscal year. Now that the new fiscal year is starting, his team is ramping up to do the query piece of it. My team and my IT team are focused on the recipient. So we're creating sort of a receiving sort of gateway in this pilot to be able to receive the pilot information, a query. So as Dr. Ezzeldin was saying there right towards the end, he's working on the query. So adverse event reports go over for immunization, and ultimately, trying to get my thoughts here, his team wants to be able to say, we want to be able to pull information on that particular adverse event report that came across. And what we're doing is we're collecting 18 clinical resources, FHIR resources, to be able to bundle those up and send them back over. So we're targeting right now to have that phase 2 work done, hopefully December, January timeframe. That's probably a stretch for my IT team, but I think we can be ready to, we have all of our mapping's done now, so we're on target to be able to get the response piece back to the FDA, hopefully in the January timeframe. If December would be nice, but I don't think that's reality. Ultimately, where we're going to go beyond that, hopefully we kick off in the spring of 2024, is doing a clinical quality language, and I'm at 10 minutes, so I'll get off the stage here shortly. But we'll do a pilot with the FDA's myocarditis CQL query, and we'll do a CQL. Then we'll receive that, and then we'll send back the information. Hopefully that will be, we'll be able to do that without manual intervention. I was going to share with a lot more slides, but I talked too much. But this is where we are today with our VA adverse event reporting system. We send faxes to both the CDC, we send faxes to the FDA for our adverse event reports. Horrible way to do it, manually intensive, not the way to do it. If my query, if our bidirectional thing doesn't work, at the end of the day, we're going to modernize our adverse event reporting system in the VA. That's going to be a huge win. I've got more, but I'm going to stop right there. Go back one. What we're doing really quickly before I turn it over to Dr. Ray, right now we've been focused on the COVID vaccination adverse events. We've already mapped all immunization adverse events. We're going to be able to send those to the FDA and also all medication adverse events as well. We also want to get partnered up with the CDC and be able to send that. That way Vaughn and his adverse event reporting team can completely replace their system. And where we go from there, once we do this bidirectional piece, we will get there. It's going to open the door for us to bring on new partners to test with us and do more things. So Dr. Ray, please come on board.
Hello, my name is Ray Duncan, and I'm from Cedars-Sinai in Los Angeles. Here to talk a little bit about our participation in the pilot Both interoperability and FHIR have been a big focus for us. eHealth Exchange was the first national network we joined in 2015, and we've been working with FHIR really since DS2.2 came out. We worked under NDA with Apple on their implementation at Apple Health. We built and installed a number of apps since then, and for the last few years, we spent a lot of time training the companies in our healthcare IT accelerator to use more modern methods of integration with EMRs, and as FHIR has evolved to version 4, it's really become practical for that to be the main method of integration for a lot of these startups. So let's see. So the legacy process at Cedars was a manual process, just like you've been hearing from the previous two speakers. Ever since at least the EMRs were implemented, there's just been a daily report generated of adverse events out of the EMR. It gets emailed to pharmacy. Pharmacy kind of trolls through it and decides what they think is important. Then they go online and fill out the VAERS form, which probably the process for us really hasn't changed since the browser was invented in the 90s. And then the FDA presumably does whatever they do with it. So there's a lot of holes in this process. Just looking strictly at COVID vaccinations, we aren't a big vaccination public delivery point. We mostly vaccinate employees, patients, families of employees, medical staff. So we don't have the huge numbers of COVID vaccinations that you would see from a public vaccination point like CVS maybe. So in the 2-year period we looked at for this pilot, we had 195 documented adverse reactions. Most of them were minor. Pharmacy actually only reported 5 of these, which they which they considered to be anaphylactic reactions to the FDA through the VAERS form. So as you can imagine, there's a lot of holes in this process. So if there was an adverse event that got dealt with somewhere else besides at our organization, probably we would never know about it. A lot of our medical staff are private. Maybe they deal with these things in their offices and we don't hear about it using other EMRs. Pharmacy can be wrong in what they report. So there's just a lot of holes in the process, as you can imagine. So if some of you haven't seen the VAERS form before, it's a big form. It's a complicated form. This is just showing like the top third of the first page of it, I think. So it's a very manual process to take that daily report from the EMR, triage that, fill this out on the form and submit it to the VA or to the FDA. So, did I go too far? Can't figure out how to go backwards. Well, so the first phase of the pilot was the pull phase, as both of the other speakers have talked about. So we basically just downloaded a client ID for our public FHIR endpoint from the that the eHealth Exchange could use. The reporting process was pretty much the same, but for testing purposes, since only 5 had actually previously been reported to the FDA, we gave them a more complete list of all the adverse events, just so that they could really test the data retrieval. Now that Epic is our EMR, they support US CDI version 2. So it's a pretty complete look at the clinical chart. It doesn't have a lot of other information you might want, like financial information, but it's a pretty decent look at the clinical record of the patient. So what we did separately for testing purposes, we sent larger lists of patients with their demographics to the FDA. The FDA could use that information to connect to our FHIR endpoint, look up the patient, and pull the various information that they were interested in, like the medications, the diagnosis list, the problem list, the immunization records, and so on. So this is just a quick diagram of kind of the data flow, recapitulating what I just talked about. I know that the slides will be available for download, so this is probably too hard to read at a distance. So for phase 2, I think we went live with that first part in 2021. For phase 2 is a push and pull use case. So what happened was the FDA supplied us with the clinical query language, which is kind of a high level, almost like a pseudo language, for 15 different adverse events. And we picked out one to work on, which was myocarditis, pericarditis. One of our wizard data analysts converted that clinical query language to ANSYS SQL so that we could run that against our reporting environment. And we used that, those queries to build some kind of staging tables. We spent a lot of time optimizing this. Adding other adverse events would be a much quicker process because now we have it pretty well optimized. Then there's the Mirth interface engine, which we use for kind of these proof of concept projects. Reads the staging tables, marshals the patient identifiers into a FHIR bundle, and pushes that to the eHealth Exchange endpoint for use by the FDA. Then the FDA can take that bundle of patient identifiers and then query those patients one by one against our public FHIR endpoint to retrieve the full chart. So this is just a high-level data flow diagram again that you can download later if you're interested in it. So there were a lot of problems and lessons learned. Manual translation of the CQL. The CQL is quite high level, so even if it was translated to something that could run against our reporting repository, it needed a lot of optimization, and we went through several different approaches over months to try and really speed this up and get it from running in, hours to minutes. Then there were various tweaks to the algorithm that we worked on with IBM and the FDA and eHealth Exchange, because we found that some patients were falling out that shouldn't fall out for various reasons that I've kind of listed up there. Sometimes the labs didn't get back in time. Since we were looking mainly at inpatients, sometimes labs would come back after the patient was discharged, and so on. So by adjusting the criteria, we were able to fix most of these issues. I think that the problem with scaling this thing up is, even every Epic implementation is a little bit different in what might be in the reporting repository. I mean, FHIR is standard, but all the things behind FHIR are not so standard. Then other EMRs have other types of reporting repositories, and are gonna need different queries. And lastly, well, not really lastly, but then there are security considerations. For example, in our EMR, a fair number of the patients are marked as break the glass, which is like an additional level of privacy protection for VIP patients or employees or families of employees or just patients that have asked to have their record marked for additional privacy protections. So it took us a while to kind of work out the best method to work around that for FHIR accesses by the FDA. Eventually we figured it out, but it took us several different tries to make it work. Let's see. All right, well, I think that's probably all the time I have, judging by the little sign that lady got held up, so. I'll see you all later.